From a very interesting MIGS session, we moved to the IPGS session. And I'll be talking about why detailed phenotyping matters in children. So I'll be giving some case examples, which are like everyday case examples in our practice. So in a life of a pediatric glaucoma person, it is a very, very common scenario that a child will present to you. This is a neonate with cloudy cornea. And then you are to figure out whether it is glaucoma or a corneal disease and how to manage. So when we think about phenotyping the child to diagnose what he's having, it's important that we do a thorough evaluation. Cornea, tonometry, gonioscopy, fundus, perimetry, examination under anesthesia, anterior and posterior segment imaging. But it is a small baby, so how to go about it? So examination under anesthesia plays a key role in making us understand the various, the characteristics that the patient presents with. But many a times we do not have this facility in the private practice or maybe in a community setup where one may be working. So there are some tools which can help us know the characteristics of a baby with glaucoma, even at a center where the EUA facility is not there. So this was a simple technique for measurement of corneal diameter. Using Schirmer's strips, a threefold is created, a U type of a tool is created, and a photograph is taken with the help of, the eye of the child is opened forcefully by an attendant, and then a photograph is taken, and then corneal diameter is discerned. For example, in this photograph, in this collage, the first one is a normal child, and the other three have enlarged cornea, as can be depicted on the calipers. Other than that, the baby, when he's well fed or maybe sleeping, tonometry, like making the use of eye care or tonopen, can help us decide about the IOP. And of course, digital tension comes in very valuable in such settings. For fundus examination, for very small babies like in C, we can actually hold them and take the fundus examination if the cornea allows the clarity. And sometimes indentation is also possible. However, sometimes we do need sedation for these purposes. And with the use of handy the cameras, it's easier these days. And of course, Sushmita ma'am's technique of flying baby OCTs, where the child who is awake can be taken for an OCT with the help of an assistant. So when we come back to that first case who presented to us on day 7 of his birth, and we took him for an EUA, and we can see that there was a dense central corneal edema and a peripheral clearing. So we went on to do a UBM, and we could see that there were both a PDL and a Descemet membrane break with a highly edematous cornea. And of course, the angles were crowded. And on a different section, we could see some vacuoles suggesting the presence of acute corneal hydrops in this baby. And a trapless trap was done, as the angle did not allow visualization for an internal trabeculotomy, and the baby's cornea cleared eventually. So a similar case with cloudy cornea presented to us, and we took him up for EUA. And after that, we also did an OCT for him. And what we saw in this was highly thickened cornea measuring up to 1.15, that is more than 1,000 microns in thickness. The IOP was borderline normal, and the difference in this case was there was no peripheral clearing compared to the first case. There was diffuse corneal haze and a bluish discoloration. So since the IOP was also not so high, we went on to do a genetic testing, and this child came out to be positive for SLC4A11 mutation, confirming the diagnosis of SHED. And when we look about the differences between the two etiologies, of course, the corneal thickness, which is uniformly thickened, unlike in that case where it was central corneal edema, this cornea is uniformly thickened and usually more than 1,000 microns in thickness. And the OCT will show you the epithelial layer, which is thickened with underlying irregular Bowman's membrane. Compared to PCG, where you may have evidence of DM or PDL breaks and irregular thickness, of course, and the cornea will clear when you do the surgery and the IOP will come down. Of course, all of us may have burnt our fingers in doing operating trab in a case of SHED when the patient comes very early on in life. So the angle appears normal in SHED cases, and the iris and the ciliary body are, of course, normal, whereas in PCG, you may find some membranes blocking or a high angle insertion, iris insertion on the ASOCT also. This is another patient with corneal opacity and limbal stretching with high IOP who presented to us, and we took him for the EUA. And here on OCT, we can see that they were so this is the cornea, which is opaque, and we can see that the endothelium beneath it is irregular. So this is a typical appearance of a von Hippel kind of corneal ulcer, which is described in a case of Peters with iridocorneal adhesions at the margins of this ulcer, confirming the diagnosis of Peters. It can present in various variations. Sometimes you may also have lenticular adhesions to this area, and sometimes you can have a very deep excavation of the endothelium, suggesting the presence of Peters anomaly. It is important for us to know the diagnoses which are not primary congenital glaucoma, because sometimes they may be associated with systemic findings. For example, this is another baby who presented with cleft lip and cleft palate, and he was on EUA with cloudy cornea both eyes, and on EUA he was found to have iridocorneal adhesions, and we did a TRAB along with an OI for this baby for long-term visual prognosis. Similar appearance of central corneal edema with peripheral clearing, high IOP, and the patient was taken up for EUA followed by a plan to do surgery. And as the patient was taken up for pre-anesthetic clearance, he was found to have an ASD by the anesthetist, and then before going for the surgery, we got a torch examination done, and the baby and the mother came out positive for IgM rubella, and he was diagnosed to have sensory neural hearing loss eventually when he grew up. So this is also important to know that sometimes in a congenital glaucoma, you may have systemic associations like that of torch infection. Sometimes babies present to you after they grow up a little older to allow a good slit lamp examination. The cornea has cleared up, and they have been treated elsewhere, and they present with glaucoma. So this is again a series of patients that we saw for rubella with a triad of cataract, sensory neural hearing loss defects, and the heart anomalies. And this is a double ring size sign that we had described for these babies, where there is peripheral stromal thinning with hyperpigmentation because of the loss of the stroma. And this is a pathognomic feature of rubella in these patients. Again, this is a hugely stretched cornea with corneal edema, and we presumed it to be a PCG preoperatively, but when we took him for the EUA, we could see a ectropion which was present. So these babies, although we did not get a genetic testing done, we usually take the blood sample when we take the baby for the surgery, and the result comes out later. But this is definitely a case of CYP1B1 associated congenital ectropion UVA with secondary glaucoma. And these babies, it is important for us to know the phenotype, and because the plan of the surgery depends. Usually these babies are refractory to surgery, unlike PCG, which behave very well with GAT or the internal trabeculotomies only, but these babies have a difficult course despite doing a trap plus trab also. So another similar baby, we thought it to be a PCG. We took him for the OT, and we can see a central harp strike kind of a picture with the central corneal opacity. Plus, we could see some peripheral hypoplasia of the cornea. And on gonoscopy, we could see actually typical high pass and a posterior embryotoxon suggestive of ARS. Sometimes, the diagnosis changes once you have made a diagnosis, operated on a case, and then the child grows bigger and develops dentition and develops good facial features. Then you realize that it was actually a case of Exenfield-Reiger spectrum, which you had previously presumed to be primary congenital glaucoma. So this is also very important to revise your diagnosis once a child grows up. So this was diagnosed as a case of Exenfield-Reiger spectrum, and of course for these babies, internal trabeculotomy doesn't work, and we did a trap plus trap for this child. So on ASOCT, these babies may have different features with different severity of the glaucoma. We can see the entire iris is attached to the cornea here, and again, it is attached with a thick pass here. There may be a posterior embryotoxon only, or there may be various variations of the attachment of the iris to the cornea. So when they grow up, it is important to delineate what kind of feature they have. They may have only a posterior embryotoxon, or they have well-defined, iris strand, mid-peripheral iris strands. The periphery is almost clear, but the iris stretching up from mid-periphery, going up to the posterior embryotoxon at different levels. The dentition is abnormal. There is telecanthus, hypertelorism is there, and of course the ASOCT features. And when you look at systemic features, they may also have features like umbilical hernia. So when we talk about ectropion, it's not only a congenital ectropion uvea where we find it. So when we phenotype, it's important that we correlate that with genotype also and with other systemic feature. So this patient, we can see that there is kind of ectropion and the iris is getting hypertrophied and coming over in the superior part. And this was an adult patient with unilateral kind of a presentation. It was actually a case of ICE, which can have localized ectropion in this manner. This patient, we can see this is a hypertrophic ectropion UVA in this patient, again presented with glaucoma in the middle age. And he also had a plexiform neurofibroma of the eyelid, and neurofibromatosis was the diagnosis. This is a case of secondary glaucoma with ectropion in a case of neurofibromatosis. And these three are different variations of ectropion that we can see in a case of Exenfield-Riger spectrum. We can see all of them have some kind of polychoria here. Here also polychoria is there, and ectropion and correctopia is there. And mild variations of ectropion can be there because it is an anterior segment dysgenesis and can present with various variations. Sometimes you may have partial aniridia also in these kind of children. So coming up onto developmental glaucomas from this stage, when we talk about juvenile open-angle glaucoma, on gonioscopy we can have various phenotyping, and in this case we can see it's almost like featureless angle, but here we can have prolific iris processes. And when we look at ASOCT of these patients, they can have different variations. For example, in this case, we have a membrane onto the angle with not so well-formed Schlemm's canal, but here it's almost like a normal angle with a well-formed Schlemm's canal. Do I have time? Okay. So in this JOAG, we saw that based on the angle features, we can actually characterize them, and we can actually say that whether they will be responsive to SLT or not. So good phenotyping can help us prognosticate the response to therapy also. This is just one of the papers which can tell us about the response to SLT, but of course there would be ways to determine whether this particular patient will respond to your angle surgeries or not. So with the use of AI, of course, this will be the future where we can look at the angle, we can phenotype them, and can decide which patient to take for which surgery. Similarly, this was a case series where we actually did the cluster. This is Dr. Vinay's work, and where he did this gonio photographs and classified the angle into various various types. Also, the crypt morphology was characterized into 3 different types, and this is how the patients were clustered based on the presence of iris crypts and the angle, and based on this, prognostication can be developed. So in the time of AI, there are various available tools in the pediatric series. Yeah, this is the last slide. So where these models are available, so it is in the coming times, it is all the more important for us to phenotype our case as well, to be able to create something which is more useful and predictive. For example, these models talk about using periocular photos for the glaucoma and in patients without corneal opacities, and many, even for ROP, these facilities are available. So to conclude, phenotyping in kids is rewarding in many situations. It plays a huge role in accurately diagnosing, guiding decisions for genetics and surgical management, and also prognosticating cases in many eyes. And in future, it holds an immense key in developing AI models for major diseases. Thank you very much for patient listening.
Thank you, Shikha, for the wonderful talk. I think now we have Dr. Sushmita. For does genetic testing help in the clinic?
After that, Sirisha. It just started when I came. Yeah. I was in some other session.
Good afternoon, and I'm very proud that we are probably the most attended session of the conference this time, apart from the speakers and the panelists. So welcome, and this is just a quick recap of whether or not genetic testing is really required and how I use it in my clinic. Many of you might have seen the photographs of these children when they were babies, but they've grown now, so I thought for context, let me share the stories now that they're growing. And of course, the photographs have all been taken with consent. So it helps me, now that we've understood it a little bit, to predict which family member has a risk of disease. That's important. Presence of absence of a variant might guide us towards which family member needs to be seen, and plan for follow-ups of asymptomatic members accordingly. And of course, genetic counseling by predicting the risk of transfer. And some cases now we can predict the prognosis of CYP1B1, which means some variants have more severe disease than the other. And where the diagnosis is not certain, we've eaten humble pie a lot, and it aids decision making and counseling. So I'm just going to go through how we use genetic information in the clinic and some stories of how we are hopefully wiser. So I know I've shared this, but just in context, this is the baby with neonatal onset glaucoma who we did a trab, stayed all right for a year. Then we did a tube, stayed all right for a year. But it went on and on until he required the ADI, and the ptosis became more marked. And at 7 years of age, his pressures were controlled on 3 meds, but we didn't understand what the ptosis was about and why he had such intractable glaucoma. Then genetics, and after we did a targeted exome sequencing, which was the clinical exome, no pathogenic variant, but I got an email. And the email said that there is an intronic variant in the NF1 gene. And when we called him back in and looked for them, we actually saw small cafe au laits. No, I'm sure we might have missed them because we didn't look for them, but remember that in neurofibromatosis, cafe au lait takes time to develop. So it's usually at the end of the first decade. So in a very small baby, unless you have a very high suspicion, you might not see it. And so it's important to have a conversation with the lab, and then we told them to redo the test, and you see the report that they give you is NF1, which is autosomal dominant and pathogenic. Then we sent him after 7 years for intracranial workup, and he does have a meningioma, but it's on follow-up because it's not growing. So we miss sending that. He doesn't have an optic nerve glioma. He's 10 now, he's in class 5, and the pressures are controlled. The optic nerve in the left eye is affected in the sense that it has an RAPD, but the intracranial tumors are stable for 3 years. So we have a responsibility, and that responsibility, this child has really made us wake up to the requirement that we need to be really, really careful. And once we had this oversight, now we have insights. So a baby with unilateral glaucoma, weird looking, with a weird looking eyelid, and we always think of neurofibromatosis. This, of course, we just send and we say we are looking for neurofibromatosis. 2-month-old baby, unilateral ptosis, looked for cafe au lait, found them, asked for NF1, got an NF1 and that. So this is how it made us wiser. But sometimes we win. So this young girl, just a very, very subtle sort of ptosis. If you can see, the eyebrows are lifted. And she had just borderline pressures. The discs were not too great, but then when we looked for it, we did find these cafe au lait. But it came out to be SOX2. So you go back to your lab this time, you win, and you say, listen, look for the SOX2 is for tuberous sclerosis. So they said, okay, let us look for it again. And you really have to tell them to analyze NF1. And once they do that, they find the gene NF1, which even an NGS can miss. So your phenotype has to be so, so important. And sometimes now you become better clinicians and you win over them and say that, listen, this is something which I'm looking for. Of course, we know these, I've shown you these aniridia pictures before. This is classical PAX6 aniridia. 3 members of family have it. And there's foveal hypoplasia, aniridia, nystagmus, and glaucoma. But we've also learned that a FOXC1 deletion can present as aniridia. So you see this preterm glaucoma, once it's cleared, there's no iris. We thought it was aniridia. The genetics taught us it's that. The thing is that there's no nystagmus. So this child, now when he grows up, you can see the telecanthus and flat nasal bridge. Whereas this baby, again, we diagnosed aniridia on table, missed a CYP1B1, which was the severe iris hypoplasia. And now we know that if you don't have nystagmus and there's absence of iris, so aniridia is only morphology. It has nothing to do with disease. So we phenotype as best as we can. We've been doing this for a long time. Now you can reach a stage where you see a baby and you guess the genotype. So now you learn a little more. So we see something like this with a spindle-shaped corneal opacity and very, very severe glaucoma at birth. We think it's CYP1B1 R390H. We see an aniridia with nystagmus. We think it is PAC6. We see this silvery cornea, which we're scared of CPA. We think it is FOXC3. We know this is NF1. We know this is a FOXC1 deletion because there's no iris, but look at the telecanthus, look at the flat nasal bridge. And we also know that in a neonatal onset Sturge-Weber, there's going to be no yield because it's a somatic mutation and you're not going to get it in the blood. So we do know, so we learn to recognize. And again, we're learning. So this is CRE BBP. We didn't know what this was. We thought this was Peters. When this diagnosis came and we looked at the stubby fingers and toes, it turned out to be Rubinstein-Tybee. And there are very few reports of congenital glaucoma in Rubinstein-Tybee. So actually, we could report that. And this is another learning. We thought it's a corneal decompensation following cataract surgery. And it came out to be ASPH because of the nose, the characteristic nose. This is Trabolsi syndrome. And there is corneal decompensation because it's a collagen problem. You can have spontaneous blebs, so you don't have to do scleral surgery at all. But this is a Trabolsi syndrome, and we know it is ASPH. So when we see many of the same in the same region and the same variant, we often guess, and this is my geneticist Pratik who's told me that, listen, we are getting so much of R390H. Can you look at a phenotype and say it's R390H? I said, my residents look at a phenotype and tell me it's R390H because they don't let me do angle surgery. They say you need a filter. So it's as if that is so. If you see it, I'm only going to do a Sanger's of the R390H of CYP1B1. If it is negative, we will go on and do the NGS. We've started doing that. So now the report is in 48 hours. It's just that one variant, you know it is biallelic homozygous. You just screen the parents, and once they are carriers, so we just do the Sanger's. We don't do the NGS anymore. And then you screen the parents, they are carriers. You tell them the risk of the 25% chance in the children, and they're happy not to. So this little baby has also grown up, got bilateral optical iridectomies, is going to school. Genetics has made us eat humble pie, of course, beware of routine steroids. So this child actually had iatrogenic Cushing's because we didn't know such a thing existed. When we did it and investigated, it turned out to be a USP11. Now, USP8 is responsible for Cushing syndrome. So maybe it's the same family. We just gave them 4 times steroid following goniotomy, and he gained 3 kilos in the next 1 month. And then he had to be, of course, with the pediatric endocrinology and everything. And now he's 5 years old, and he's a normal kid. So now we know. So the punctal occlusion, which was a routine run-of-the-mill thing, now it is like reinforced. And if you think your baby is growing more than anything, come back in. So that's, and this is the last one. How little we know. This is scary, but I'm just presenting this. Bilateral ophthalmos came to us. He had a history of neonatal ICU admission for lethargy. And while awaiting PSC clearance, again, he had vomiting, breathlessness, and lethargy. So while awaiting, because the pressures were so high, we actually gave him 4-weight Diamox, which we do as an interim measure. And he was detected to have hyperacidemia and hyperammonemia. He was given bicarbonate infusion. He required mechanical ventilation, antibiotics, but the pediatric ICU had no idea what was happening to him. And then for persistent metabolic acidosis and hyperammonemia, he actually underwent a peritoneal dialysis because he just wasn't getting control. And he recovered after 5 days of ICU care. So we were still in conversation with each other. And by then, the whole exome, which has come as no variant matching the phenotype, had an incidental finding. I'll take 15 seconds more. Had an incidental finding of CA5A. I didn't even know such a gene existed. He was CA5A deficient, which meant carbonic 5 anhydrase inhibitor. He was already inhibited, and we inhibited him even more by giving Diamox because we didn't know. And this metabolic decompensation was understood to be due to the underlying CA5A deficiency. He was discharged and advised to avoid all these drugs, which would be detrimental in a CA5A. So the post-ICU discharge, he came, you can see his glaucoma had got worse because it wasn't treated for all that time that he was there. You can see the steamy cornea, the Harb striae, did a bilateral GAT. In fact, one of my fellows did it. And his axial length also reverted. And he's come back now. He's about a year old. Thank God, cross fingers, we're okay. So the sobering realization is that coexisting PCG in these patients may precipitate a metabolic crisis if you treat them with acetazolamide. So I would say my key takeaways are we can unravel genetic factors, it facilitates early diagnosis, and informed treatment is possible. So I think it's been a huge value addition for us, and I'm sure if all of us do start genetic testing, we'll all be better clinicians there. Thank you. I acknowledge all my residents, fellows. They really work very hard for me. Thank you.
Thank you.
Sirisha's is a recorded talk.
Yeah, okay. So thank you, Sushmita, for a wonderful talk, as usual.
Thank you.
So now we will have.
Sirisha का recorded talk होगा, Dr. Sirisha.
ऑडियो नहीं है
Hello friends, I'm Dr. Sirisha Sendil and the topic I will be talking to you about is has genetics improved the management of my glaucoma patients? I have no financial disclosures to make. So why genetics matters? It matters because glaucoma is one of the most heritable condition that we see and genetics definitely add molecular precision and predictive insight to the patients that we treat. So we also need to understand that there are several gene disease pathways that are known and more than 100 genes are known both in the early onset glaucoma as well as adult onset glaucoma today. But do we order genetic tests for everybody? We usually order genetic tests, at least in our clinical practice, for those with early onset or glaucoma or bilateral presentation, those with a positive family history, those with syndromic associations, or when we offer a particular type of treatment and the response to it is not as expected, or if they have a very refractory nature of the disease. For me, genetics definitely helps to confirm diagnosis in several conditions. It also helps to predict the severity of the disease and the response to treatment. It, in several situations, also helped me to change my management strategy and sometimes change the way I think or possibly offer a different type of surgery for them. It also helps to tailor the ocular and systemic management, especially in syndromic conditions and in those where possibly move one step ahead and try to prevent disease in the future generations. So let's look at a few examples of what has helped in our practice. Genetic testing for establishing appropriate diagnosis. Whenever we see an eye with a hazy cornea and megalocornea, it's not difficult to diagnose that this is congenital glaucoma. We need to understand that every elevated IOP, every megalocornea, or every bilateral corneal haze is not necessarily a primary congenital glaucoma. We may be dealing with a condition that could be secondary, or sometimes we may be dealing with a condition that's not even glaucoma. So oftentimes in our clinical practice with experience, we may be able to assess whether this is glaucoma or not. But then sometimes when there is a dilemma, genetic testing is something that we look forward to, and that helps us to confirm the diagnosis. And once we know that this is a particular disease, we may offer a different kind of treatment. In some situations, we may not even treat them surgically. So all of these with hazy corneas, to the same type of intervention that we do, their response may be very different. And that's the reason why I think it helps us to understand which of these conditions respond well to treatment, which of these conditions may not respond very well. And sometimes, like I just said, the last picture here is possibly associated with a congenital primary aphakia, where an intervention would actually be disastrous and one should not be offering any intraocular surgery for them. In situations where we call it as aniridia, where the absence of iris, all aniridias or all absent iris are not typically the aniridia that you see that is associated with PAX6. Sometimes you may see it associated with other anterior segment dysgenesis like PTX2 associated condition or a CPAM-D8 associated condition. Each of these have different kind of presentations. Each of these responds differently to treatment, and hence it's very important to identify deep phenotype as well as do a genetic testing to understand the molecular basis as well. Sometimes it also helps to manage and prognosticate. Like I said, all SIP1B1 associated primary congenital glaucoma need not necessarily behave the same way. Some of them, like one surgery can help to clear the cornea. Some may require multiple procedures. Some may require an early tube intervention. Some may require a keratoplasty. So what we need to understand is, though it is SIP1B1, but depending upon the variant of the mutation that you have, you also, the response to treatment may vary and the severity of the disease may vary, and that helps us to prognosticate. Sometimes we may also tailor our surgical management accordingly. So this was a child who was presented as a primary congenital glaucoma with an enlarged corneal diameter and a corneal haze in the right eye. But what is very striking is this child, despite the enlarged corneas, did not have HAPS striae. There was a mild corneal haze, but there was also some pupillary changes that we saw. There was a subluxated lens and very high myopia. So this child had ectopia lentis and the intraocular pressures and discs were healthy. What this child actually had was an LTBP2 mutation causing ectopia lentis, and that was responsible for the secondary glaucoma that the child had. Possibly an intermittent pupillary block kind of a picture, and also a lenticulocorneal touch that was actually causing the corneal haze and not the glaucoma per se. So this child actually required a lensectomy and not a glaucoma surgery. We also need to understand some of these patients can present with lens-related problem or ectopia lentis with glaucoma as well. So they may require both a glaucoma procedure as well as a lens extraction, like this child who had a CPAM-D8 mutation that was causing a congenital onset glaucoma, but it was not the PCG, and this child need to be intervened in a different way. Sometimes secondary glaucomas can also be combined with primary glaucomas. So like ROP, which is a very common secondary glaucoma that we see in our country, these children who are premature can also have a primary congenital glaucoma associated with it, and they need to be treated in a different way because especially we are dealing with a condition. There are two blinding conditions, which both of which are emergency to treat, so have to be recognized and treated appropriately. So this is one condition where we've been working on for quite some time, and we slowly are now understanding what happens. So young patients with angle closure presenting with very intractable angle closure glaucoma, and when they do a PI, that doesn't help. With time, the angle closure worsens, and these eyes require a surgical management. And oftentimes when you operate them, either with trabeculectomy or a GDD or any procedure, they end up having a malignant glaucoma or a flat anterior chamber. And these patients only with genetics, of course, deep phenotyping does help, but genetics helps us to confirm the diagnosis. So best when associated retinopathy and angle closure, X-linked retinoschisis, and CRB1 associated and RAX2 associated RP are some of those conditions with inherited retinal disorders that can have very severe type of angle closure in the young, and these eyes have to be treated differently. So how differently do we treat them? We actually don't do any glaucoma procedures in them. We know that their vitreous is very turbid, fibrillar, and very thick, and possibly is not very permeable to the aqueous, and hence a early vitrectomy and an iridozonulohydrodovitrectomy communicating the anterior chamber to the posterior segment prevents this malignant glaucoma from developing. Not just that, in fact, their intraocular pressures start coming down, the AC deepens, and we are able to do a lens sparing surgery and control the intraocular pressure in them. In about 20 to 30% of them, they may require a glaucoma intervention at a later time point, but oftentimes just the vitrectomy and IZHV helps to control the intraocular pressure. In some ectopia lentis related disorders, we know like the Trabolsi syndrome or ASPH associated mutation with ectopia lentis, these patients have very abnormal sclera. So it's very important to identify the cause of ectopia lentis, because in these patients, if we do any kind of a scleral intervention, they end up having a very thin sclera and sometimes leading to severe vision threatening hypotony. Even without an intervention, even without touching the sclera, it's also they can develop spontaneous filtering blebs. And if in case we end up touching the sclera, it can be very, very difficult and disastrous for them. So here again, it helps us to understand what the condition is and plan an appropriate intervention. It also helps us to understand that these patients can have associated cardiac abnormalities that can be that can be life threatening, and hence and knowing the condition and appropriately referring them to the cardiologist or the physician helps us to have a vigilance and possibly prevent serious life threatening complications. In patients with very severe juvenile open angle glaucoma, they are very aggressive. If especially associated with autosomal dominant myosin mutation, it helps to screen the children so that in case somebody, if the child has the similar kind of a mutation, then it helps us to periodically screen these children. And in case they develop a problem, we will be able to pick it up early and treat them appropriately. We also can go one step further in know that in familial diseases, especially when both the parents are carriers, it helps us to possibly plan a prenatal testing or sometimes even a pre-implantation genetic testing, and that helps to prevent this disease in the future generations. So the future is here. We know gene therapy and targeted treatment is something that people are aiming for. Sometimes gene-based therapies have shown promise in juvenile open-angle glaucoma, and they're also coming up in certain other types of secondary glaucomas that, like the neurofibromatosis type 1, which are showing promise, and especially with the MEK inhibitors that are there, which are used to treat the severe form of inoperable plexiform neurofibroma as well as the intracranial neurofibromas. So I would conclude by saying genetics definitely is here to help us. It helps us to refine the diagnosis and prognosis, enables us to individualize the care, prognosticate our care, as well as choose an appropriate type of intervention and surgery. Also helps us to prevent certain complications in these patients if you know what exactly the condition is. And like I said, gene therapy definitely holds promise, and the future looks definitely promising and optimistic. Thank you so much for your attention.
Questions? Mike?
Let us complete this and because time is a problem.
Time.
All right. Sorry.
So there is not much time for the question, but just I think one or two questions. I think since we have started having discussions about genetic and phenotypic correlation, our understanding has increased tremendously. So I think all the panelists can answer is like what type of genetic testing will you advise for a pediatric glaucoma? Will it be a particular gene or a panel or whole exome sequencing, just for the audience?
My understanding of genetics is extremely poor. While I was in LB Prasad, I used to interact with the geneticists. They used to take their guidance. Sometimes I used to request them to come so that I can show them these are the features and this thing. That's the way I used to do. Now, Sirisa is doing in a probably more scientific way. And what do you feel about your idea?
So our geneticist he says that we have to do at least 10 or 15 whole exome sequencing to see what is the pattern in our population, and then we can go ahead with the short testing for one or two genes. So that's what he says. So we always collect blood and keep doing for the whole exome sequencing, and then go ahead with the shorter ones.
I think Dr. Sushmita gave an interesting talk about how do we match genotype and phenotype. So as we generally talk about positive predictive value of a test when we are advising any test, similarly for the genetic testing also, I feel if we have something where we are expecting something looking at the phenotype, doing a particular gene would be a better idea rather than having whole exome. But yes, as we are learning in the process and we have to understand what is the prevalence of particular genes in our population, that would be a good idea. I think all of us are limited by the availability and the cost of these tests. So in that light, I would prefer to do a phenotype related genetic testing in a given situation.
Your thoughts, please.
Yeah. So I just would like to add, I totally agree with Dr. Sushma. Basically, we plan the genetic testing based on the phenotype. Like, for example, if it's Sturge-Weber, there's no point in sending a whole exome sequencing. We have to send a skin biopsy in the area where the hemangioma is and then look for a somatic mutation. If it's a NF1 and we know there's an S-shaped ptosis, then we go and ask them to do directly for NF1. So, and CYP1B1 also, there are so many variants that we have seen. We've been doing genetic testing from 2021 and we have seen so many variants, and it is impossible to tell that the variant, it looks like CYP1B1, but this variant behaves well or it gets treated with one intervention or this. So it's mostly the treatment is based on the disease course or the phenotype. We don't depend upon the genetic testing, but still there's lot of knowledge has to come out and what we have to learn. Yeah, thank you.
Yeah, so when the phenotype is pretty much there, and you've seen like possibly R390H is a hotspot in our population. So then the thing is, you go along with the Sangas, which is cheap, and it comes, and if you don't have it, be prepared to do a whole exome. Right, so we shouldn't close our minds to the fact that if we don't get it, then we're not going to do that. But yes, like Rashmi said, some phenotypes are now so typical. I mean, CPA, NF1, maybe aniridia with nystagmus. We don't even think of anything else. So in that sense, it's our limitation of knowledge earlier, which limited our thinking. But we've learned so much. So when the phenotype is garbad, then I always do a whole exome.
So, like you only presented a few cases where there's a lot of overlap, and there are few genes like CYP1, V1, LTB, P2, FOXC1, PTEX2. So, is it a good idea to have a panel of these common 8 to 10 genes, because some companies are coming up with a panel?
Yeah. When we speak to the labs, they say that in any case they do a whole exome.
Yeah.
And they only analyze whatever panel you're saying. So it's not that they do only the panel. The problem with doing only the panel is, especially if I'm not sure of the phenotype, is I would have missed a lot of things which I wouldn't have. So that's it. So it's not as though the panel is advantageous in terms of cost or in terms of doing or in terms of time, and therefore we do a whole exome. Really.
And you said within 48 hours you get the results,
Sangas.
right?
Just a Sanger sequence.
That's
just
all.
a sequence of that one variant. You'll get that in 48 hours.
And that's done in your hospital.
Any lab would do it.
Any
Sanger's is easy. You have a primer, they'll just run it.
No, all other practitioners, no, just
So MedGenome and other labs are there.
yeah.
Any genetic lab.
Any
would do
genetic lab. So I think in the interest of time, we can start the case presentations.
So everyday puzzles. We can call the next team.
So can we call Dr. Sushmita and the panelists on the stage, please? Dr. Shanta is there? Shanta is not there. And Gauri is also not there. Shahinur, I think no one is there. Some of them. Parivardhani?
No, she's presenting the first one.
What is?
No, Devang is the first.
Dr. Purvi? Yeah.
So, Dr. Devang, you can... Is Dr. Devang here?
Yes.
Yeah, come. We just have 15 minutes, so it's going to be a quick...
Yeah.
If you can do a quick 3-minute, it'll be nice.
A very good afternoon. So I would be speaking on, the slides are not there on the screen. Yeah. So I would be speaking on unraveling a case of primary congenital glaucoma with CTEV, that is congenital talipes equinus varius. So this was a 4-month-old child who had presented with an increase in size of the eyeball since birth, along with watering from both eyes. In birth history, the child was born through a normal vaginal delivery at home and cried immediately at birth. There was no history of NICU stay. The family history shows that the child was 4th born child of a non-consanguineous marriage with no significant family history of any similar complaint. in case in general physical examination, what was characteristic was there was dysmorphic facies with prominent forehead, buophthalmos, anteverted nares, and thin upper lips. Also, with this, we found a bilateral foot deformity. The right foot had a calcaneo valgus, and the left foot had a CTEV, which was in the cast. So the multi-system involvement made us to go further for investigate a thorough systemic evaluation, genetic analysis, and examination under anesthesia. So on systemic analysis, we did an ENT examination which showed bilateral congenital sensorineural hearing loss was noted in the child. And it was further advised for a CE MRI brain with inner ear and HRCT temporal bone for complete anomaly assessment. The cardiovascular, respiratory, and CNS examination seemed to be within normal limits. USG, KUB, and abdomen was also within normal limits. But as shown, that orthopedic evaluation and skeletal survey showed that there was a characteristic foot deformity. On the right side, there was calcaneo valgus, and the left side, there was equinus varus. So we had sent the child for a genetic testing and counseling. However, the Indian scenario being that the patients were not affording, and meanwhile the patient needed further examination. So we, in the absence of molecular confirmation, we relied on the phenotype, and also consulted our pediatrician. So with the pediatrics, we had points in favor of Frank-Ter-Haar syndrome, which the points in favor were congenital glaucoma, dysmorphic feces, and CTEV. However, in our case, additionally, we noted microspherophakia and bilateral sensorineural hearing loss. The points that was against was there was no cardiovascular abnormality, but we went ahead with a probable diagnosis, which was not yet confirmed. On examination under anesthesia, we could see that there was buophthalmos with a horizontal corneal diameters of 15.5, with diffuse corneal haze, which was more on the left eye as compared to the right eye. The CCT was thickened, and the pressures were 12 and 14 on 3 AGMs, and the axial length was also elongated, and we could see a characteristic microspherophakia with a temporal aniridia in the right eye, temporal loss of iris, hypoplasia, and the vertical cup disc ratio was 0.7:1, and in the left eye it was near total cupping. So these also was suggestive of some sort of congenital glaucoma, but the lens abnormality was more suggestive of some underlying genetic defect. So we further went ahead and did a left eye trapless trab with mitomycin C, followed by right eye 360-degree goniotomy. The child was followed up in the CTV clinic to ensure correction and rehabilitation of the foot deformity. The child was also advised to use of a hearing aid along with speech therapy. However, we did address the IOP, but the underlying syndrome was not yet evaluated. On follow-up, when we were seeing, we could see that the corneal haze had cleared up, the corneas had cleared up, and the IOP was now controlled without any medications. And after multiple sets of counseling, and the patient did go ahead and did a genetic testing, and to our surprise, where we were suspecting FTHS, in which the gene was SHP3D8, we did not get that gene. Instead, we got a CYP1B1. So CYP1B1 was pathogenic, and to our surprise, we got a gene genetic mutation in VPS33B. So this made us look into what is VPS-33B. Our entire diagnosis of FTHS was now basically cancelled, and we then looked into what is VPS33B. So basically, it is a gene that encodes protein of SEC1 domain family, and what is the importance is that any mutation in this gene leads to defective vesicle trafficking, and it leads to impaired AC, anterior chamber angle development, defective cell porality in the tubercular meshwork, and possible zonular instability leading to microspherophakia. So the glaucoma here is developmental and not merely pressure driven. And then further digging into the this gene, we could find that there was a classical triad of arthrogryposis, renal dysfunction, and cholestasis. And in our case, we did have arthrogryposis, ocular involvement, hearing loss. However, the child was very young, although ultrasound and KUB was normal, but there was no overt renal or hepatic signs yet. So we, for the moment, it seemed to be a milder ARS spectrum phenotype. So then when we For the first time I was hearing this word arthrogryposis, and we looked into the literature. The moment I saw this picture, I could just like foresee that this is the diagnosis. It was so clinching that the figure that you see, even one patient in your life, you will never forget this disease. And we went ahead and, so arthros, as it says, it means joint, kyphosis means bent, and multiplex and congenita, we know that it's multiple, and congenital it's since birth. So the good thing was that this is a rare, but it is a non-progressive condition. So we could basically counsel the parents that it is a non-progressive disease, and the surgery has a very good outcome in this patient vis-a-vis FTHS, which has a more graver prognosis for the eye as well as for the child. So we made the final diagnosis of arthrogryposis multiplex congenita with primary congenital glaucoma. And when we looked into the literature, there were only 2 case reports in which had association of arthrogryposis with congenital glaucoma. The one that we had was from India only, in IGO. It noted that arthrogryposis with congenital glaucoma. However, there was no genetic testing at that point of time, which was published in 1988. And the other one was by Zitter et al., who had basically seen arthrogryposis with juvenile onset glaucoma. And in this also genetic testing was not available.
Can you wrap
So,
up?
yeah, so the key take-home message being that congenital glaucoma is not always isolated. There are multisystemic clues must not be ignored. Lens abnormality is a strong genetic hint. Socioeconomic barriers delay precision diagnosis, especially in our Indian scenario. And genetics transform the management beyond IOP control, especially in these syndromic multi-system involvement. And management of these syndromic children needs a multidisciplinary approach, an ophthalmologist, pediatrician, orthopedician, ENT, geneticist, counselors, and many more. So at the end, I would like to say, the future of glaucoma care lies where clinical expertise meets genomics and molecular insights. Thank you for your patient listening.
Thank you, Devang, for a very interesting case. However, we do not have time for any discussion, but I think it's really commendable that you did such an extensive examination and finally came out with a diagnosis, and it's a very rare thing.
Thank you, ma'am.
Okay, thank you. So you can start presenting.
Good afternoon, everyone. Today I'll be discussing a case where the dilemma was to operate or not to operate, and let's see how genetics helped us. So we all know that ocular findings can be first clue to an underlying systemic disease, and in patients with ocular abnormalities accompanied by systemic features, genetic evaluation can be pivotal not only for diagnosis but also for preventing potentially harmful interventions. So it's a story of 19-year-old male who was presented to us with bilateral diminution of vision since childhood. Also, there was progressive change in power of glasses. 1 year back, he had a history of sudden onset pain and redness in the right eye. Then he visited local ophthalmologist and he was diagnosed as lens subluxation in the right eye, and surgery was advised. Also, the IOP was rare, so he was started on anti-glaucoma medication, but he visited us for second opinion. On presentation, the best corrected visual acuity was 624 in right eye and 6/18 with high myopia in both the eyes. Intraocular pressure was 14 and 16 on 2 anti-glaucoma medication. Angles were closed in all the quadrants in right eye with 360-degree peripheral anterior synecdoche, while in left eye it was closed in few quadrants and patchy synecdoche was there. If you look at the image, we'll see that there was mild conjunctival congestion with corneal opacity in some sectors. Also, the peripheral cornea was more opaque compared to the central one. AC was shallow. There was multiple iridocorneal adhesion, and iris atrophy along with the sphincter atrophy was also there. Left eye, apart from shallow anterior chamber, rest of the findings were normal. Cornea was clear. There was no iris atrophy, no sphincter atrophy. In both the eyes, there was supranasal subluxation of the lens. We got AIOC, and in right eye we can see there was practically no anterior chamber, and the entire iris looked like it's plastered to the cornea, and angle was totally obscured. In left eye, it was normal, except there was slight subluxation. We can see faintly in the lower part of the image. The glaucoma was advanced in both the eyes with advanced glaucomatous optic nerve head changes with corresponding visual field defect and OCT RNFL changes. So we made a provisional diagnosis of both eyes secondary angle closure glaucoma with supranasal ectopia lentis with right eye iridocorneal adhesion and corneal decompensation. But the question was, it was secondary to what? So we did systemic workup. It was negative for Marfan's, homocystinuria, and Will Marchesani, which are the common syndromes associated with ectopia lentis. And meanwhile, we also sent whole exome sequencing for the patient. Patient underwent both eye lens aspiration without IOL in November 24, and transscleral fixated IOLO was to planned in the second sitting. This is post-op day 3. Although the surgery in the right eye was quite complicated because of widespread iridocorneal adhesion and synecdoche, but patient was still reading 6/12 in the right eye with FAK correction, 6/9 in the left eye. IOP was 14 and 10 on 2 anti-glaucoma medications. We got the genetic report, and it was we got two variant. It was it was autosomal recessive homozygous mutation in ASPS gene, and another was autosomal dominant heterozygous mutation in NOD2 gene. Both of them were uncertain significance. The first one indicated the Travolsi syndrome, and the NOD2 was indicative of Blau syndrome. So if we look at the signs and symptoms of both these syndrome, in Blau syndrome only the uveitis is the ocular abnormality that is associated, that is found to be associated, which was not there in our patient. But from the Travolsi syndrome group, there are multiple features which are present in our patient, like there was lens dislocation, there was corneal clouding, there was iris atrophy. So we recalled our patient, and we did analysis, retrospective examination of the patient, and we noted the patient definitely had lot of facial dysmorphism in the form of downward slanting of palpebral fissure, big shaped nose, triangular retracted chin. Father was found to be carrier of ASPS gene. So we revised our diagnosis as both eye aphakia, status post, phacoaspiration due to ectopia lentis with both eye, secondary angle closure glaucoma secondary to Travolsi syndrome. So it's a rare genetic disorder.
I think you have to wind up now because we have one more presentation.
So Travolsi syndrome is basically
Shivani is there?
mutation in ASPS gene with multiple
Oh, she's not
pathogenic
there.
variants. Because of the limited ASPS variant, there is no clear genotype-phenotype correlation. It is also called as FT lab syndrome, which stands for facial dysmorphism, lens dislocation, anterior segment abnormalities, and spontaneous filtering bleb. The hallmark of the disease is spontaneous filtering bleb, which can lead to hypotony and even phthisis in some of the conditions. So this is the last follow-up of the patient, and our plan is to continue with the FAK correction and no secondary IOL, since the patient can have spontaneous bleb formation and phthisis. So this case highlights the importance of timely genetic testing, and recognizing Travolsi syndrome prevented a potentially sight-threatening complications. So the most successful surgery in this case was the one we decided not to perform. So take-home message from this case will be, in challenging cases, genetic testing is important, but the timely genetic testing is of paramount importance. Clinical correlation is more important than uncertain significance reporting. So diagnose first, operate later. When multiple systemic features accompany an ocular conditions, the diagnosis may lie not in the slit lamp, but in the genome. Thank you.
So again, a very nicely worked up case, and we do see Travolsi syndromes now because we do recognize the systemic, associations, big nose and low set ears and other abnormalities along with glaucoma. And I think genetic correlation is very, very important. Although they say that the treatment doesn't depend on the genetic test, but you can prognosticate and even advise the family, how the case is going to behave. And then it's sometimes when there are systemic associations, you need to have, a multidisciplinary approach to manage the patient. So I think it is very, very important. And thanks to IPGS that now we are getting to learn so much, and we have started thinking about doing genetic tests in all whosoever is practicing pediatric glaucoma. I think we realize the importance of genetic testing. You have to say something?
It was a very nice case. Just wanted to know, ma'am, if these cases we end up with uncontrolled glaucoma, what sort of glaucoma procedure is advised? Because we should not touch the sclera.
Yeah. So maybe I think one of the mixed procedures. I don't know, like I have not done, but many.
I think without touching the sclera, it's possible to do anything.
Yeah, makes, I think makes will be good option. Yeah, good option. GAT and all can be done.
I think the understanding is that we can't do much in these patients. Even the mix is not going to work, and these patients ultimately end up with scleral melt. So we can only prognosticate. I don't think we have anything right now which can help these patients.
But we need to control the pressure So
Yeah,
maybe
so
I
Rashmi-
think without touching sclera, I think if we can do some kind of procedure for
but
some
even
time.
for MIGS, you will
Yeah.
have to go through the limbus. So that is the problem. They
Yeah.
end up
Clear corneal.
Clear corneal.
yeah, either
clear
we have to
corneal.
do clear corneal and see. I don't know. I don't have much experience. If
So for MIGS, I think we do clear corneal only, the incision.
but
But we don't have that much of experience of MIGS in such cases also.
so outcome.
These are the rare conditions which
Yeah.
are
You have some experience, Rashmi?
The only thing that we have done is the lensectomy. That's also clear corneal.
Yes, yes.
So this is the only disease I feel where we wait for the genetic testing. If we don't know and
Yeah.
if they don't have a typical nose features,
Yeah.
we wait for the ectopia lentis, wait for the genetic
So
testing.
are
and
there
then
any
treat.
cases where they do not have typical features, facial dysmorphism?
no, ma'am. Most of the patients.
Yeah, they have.
they
So
have
because from the
dysmorphic
distance also
features.
you can recognize Rabo syndrome now, because we have seen some
many case
patients.
reports in
One
the literature.
patient we had of 8-year-old child, if they're very young, this typical nose features are not
Yeah,
there.
yeah, it
Only
is a
when they
possibility.
grow older, we
Yeah.
start
Deficit
seeing.
development.
So we will come to the end of this session, and thank you very much, all the speakers and panelists. Although we didn't have much discussion, but I think it's okay. Can we have a group photo?
It is typical of Paediatric syndrome. Then the patient goes of smoky, sharp, big nose. This is the hallmark of trouble. So that was the clue.